Welcome again, everybody. This is Yasser Wazifi from Learn Dental Series. We will continue our discussion about the topic of diagnosis and treatment planning in operative dentistry. I declare that I don't receive fees, compensation, or royalties from the sales of any of the products shown or discussed. Also, this presentation has not been sponsored by any company, agency, or organization and is prepared only for educational purposes. I also remind you about the copyright of this presentation, which is copyright protected and could not be transmitted by any mean unless you get a prior permission of the author. In this episode, we will continue our discussion and we will today correlate between the oral and dental clinical findings and the proposed treatment plan, and we will focus in properly diagnose dental caries by different techniques. In the previous episode, we already started to discuss part 1, including patient assessment and information gathering in terms of demographic data, chief complaint and its history, medical history, and dental history. Today, we will continue forward to discuss the clinical examination and diagnosis, especially we will start with diagnosis of dental caries. First of all, should differentiate between the terminology of examination and diagnosis. Examination is the process while diagnosis is the result, okay? Or the nomination of your examination or the result of your examination. Like that, we are examining all the students in any class, okay, regardless he is one of the top or one of the 5 bottom students. All students should be examined regardless their level of intelligence, regardless their IQ. They are all should be examined, but the leveling of the result, this one get A plus mark, this one get A grade, B grade, like this is diagnosis, the result of the exam. That's why the process of observing and testing both normal and abnormal conditions regardless the complaint is called examination. Diagnosis is the determination and judgment of variations from normal, giving a name to the abnormality we observed or we examined, or the result of the test is called diagnosis. This is the difference. Then what we are going to do is examination, okay, followed by the result will be the diagnosis. That's why it's examination procedure related to or resulting in a diagnosis, okay. We will start with our major interest, which is examination of dental caries. Examination of dental caries, as said by Socrates before, to find an accurate method for detecting and diagnosis any disease is the goal of healing art, okay? Because if you don't diagnose the condition, okay, you will not perfectly design a treatment plan to fix it. That's why caries diagnosis is not just to detect it. Caries diagnosis, okay, it is the mental resting place on the way for treatment decision. You couldn't get your treatment decision or treatment plan without accurate and perfect diagnosis of dental caries. And dental caries is not, diagnosis is not the detection of its presence only. Is it present or not? It is seen or not? It is an intellectual process in determining the present and the extent and the activity of the lesion. All of these are integral part of diagnosing dental caries, as well as not only assessment of the activity of the lesion, but also all the circumstances, the environment, the conditions related to developing this carious lesion, okay? Because activity of the lesion, okay, requires either active or inactive management, okay? Active management could be operative or non-operative management, treatment, okay? While the arrested lesion, inactive lesion, okay, needs another plan. That's why early diagnosis of caries lesion is important, because caries process can be modified as early as you discovered it and could be reversed without any traumatic management or cutting a cavity. Your management of dental caries could be as simple as modifying the oral hygiene habits of the patient and just adding fluoride application in a way or another, and could be severely traumatized as indirect restoration or may go for endodontic post-core and blah blah blah. Okay, that's why, as said by Socrates, a goal without a plan is just a wish. You should plan to achieve your goal. Let me give you an example. Okay, all of these four cases are diagnosed as Pitts and Fisher cases. Okay, if you think by the same classical routine management designed more than 120 years by G.B. Black, okay, then you will cut and prepare a classical or routine class 1 including all bits and fissures, okay, for all of these classes, while actually all recent practiced dentistry, okay, and all the recent literature, okay, and all the recent techniques, okay, will show you a different management, although they are all classified and diagnosed as simple occlusal class 1. But number one, are they all as simple as you read the word simple? Okay, are they all the same simplicity as you say simple? You say simple because it is one surface, but you didn't consider the management of the bulb. You haven't any idea about what is inside the tooth underneath this discoloration. That's why, okay, if you try to manage these four cases, you will discover that. Number one is just a little bit discoloration of a deep fissure, okay, that needs only etching of the surface and placing bits and fissure sealant, as simple as that. Okay, either fluoride containing or not, okay, or it is with application of fluoride, either topical in a professional way or topical using mouth washes or mouth rinses, whatever you will do, okay, but it is still a traumatic management. You didn't go for operation, you didn't go for cutting tooth structure. Okay, the other one shows that you just have a little bit penetration extension of your caries into enamel, okay, just touching the dentino enamel junction, but not all the tooth surfaces. If you prepare it as classical or routine class 1, that of Black's cavities, okay, it will be a massive damage. You could imagine the caries is only limited to this hole, and you will go for distracting the remaining occlusal surface, okay, and you will go just only for preventive resin restoration, just sealing this cavity, this minimal invasive cavity with suitable restorative material, okay, and accompany this with bits and fissure sealant for the other. While the third one, which looks from the occlusal point of view, just a visual examination, it looks like just a little bit extension more than the second one. But when we open this, we discovered these steps and to how extent your buccal cusps are undermined, and that's why you are applying a flexible base material, okay, and you are designing the preparation for to receive bonded restoration in a form of direct composite resin restoration, just to reinforce the weakened buccal cusps and cross-tying them with the strong palatal cusps, okay, and this is the maximum conservative approach in such a case. While another one, which seems like the third one, okay, but when we open this, we discovered a wider buccal extension to the other side, and it doesn't become simple as we could imagine. Remember that the top four pictures are termed or diagnosed as simple, okay? The third one is not simple biologically or mechanically, because already we have undermined buccal cusps and we already should evaluate the activity of the caries. Okay, if we apply the concept of GV black, then the third one, you should remove all of these discoloration and all of these discoloration, and the case will be referred to endodontist. Okay, the same for this one last one. Okay, it is diagnosed as simple occlusal class 1, but actually when we go to remove the caries, okay, we discovered a wide mesiodistal buccal extension, and the cavity becomes compound, not simple. Okay, then the simple term that describes the number of involved surfaces in the caries procedure, it is of no value in treatment planning. It is not describing how much the case is simple or difficult. It just counts the number of surfaces. When we, as you could notice here, okay, the operator trying to diagnose the occlusion, okay, and he find a massive occlusal centric holding areas. That's why he may go for indirect aesthetic restoration. Okay, and this is the final fate of your case. Then you have two cases to the left and two cases to the right. All are diagnosed routinely by the older concept as simple occlusal class 1, while the management is not as simple as that. Okay, we have the two to the right, okay, are just early carious lesion with minimal traumatic cutting of the tooth structure, while the others, okay, other two to the right, two pictures or two cases to the right, are extensively damaged. One is not as simple as we termed it, okay, because of mechanically already the caries undermined the buccal cusps, and biologically caries extended deep, okay, into the pulp. You should get a proper idea about the extension and a proper idea about the activity of your carious lesion. Okay. Also, the last one, we discovered it is not even simple, okay, as it includes more than one surface. Okay. That's why we are in need to get a diagnostic tool that could diagnose caries in the early stage of the two cases to the left rather than the two cases to the right, because we would like to manage caries, okay, as simple as it is early detected, because it is the least aggressive one. If you consider failure of restoration, okay, the cases to the left, as early as I detect dental caries, still have a chance, and another and another and another and another until reach to indirect restoration. I could repeat the restoration many times. I still have a chance to get less aggressive treatment. While those to the right, okay, I don't have these chances. I will go either for full coverage or I will go to sacrifice a pulp. Okay, and after that comes extraction, okay, and maybe fixed prosthodontics or going for implant supported prosthodontics. Okay, it go forward aggressively and fastly to more aggressive treatment. Okay, while the cases to the left, we like it because still I have too much chances to repeat our restoration. That is why caries detection method should be capable of detecting lesions at early stages as possible, when progression can be reversed or arrested. That's why we will avoid premature tooth treatment by restoration. Okay? At this stage, you are saving tooth structure, you are saving time, saving money, saving stress for you and your patient. Also considering the infection control. In general, the visit will be for few minutes, not for few hours. Okay? And increasing the time of visit nowadays within the pandemic of COVID-19 and a much spread infectious disease, you need to lessen the time required for your treatment and made it as simple as possible and as successful as possible. You should also ensure a good, perfect prognosis for your case. That's why we should differentiate between two terminologies. We should differentiate between detection and diagnosis. Okay, detection means that the determination of the presence and the extent of caries lesion, including its activity. That's it. But it is not that simple as a diagnosis, not only determining the presence of dental caries and extent of its activity, but also we should report the risk factors, including patient attitude and behavior, because all of these plays an important role in the success of minimal invasive atraumatic preparations. Okay, because proper early diagnosis constitutes the cornerstone of treatment planning and success and prevention of recurrence. That's why we can't treat what we can't see, so you should inspect and see the problem by a way or another from all aspects and from all dimensions. That's why the proper caries management plan could be assigned only if you could see your caries in 3D, in three dimensions. What is meant by three dimensions? The first dimension is early detection. Okay, then the second is the contributing and risk factors which affecting its third dimension, which is the activity. That's why when you would like to design a preventive program, or when you would like to reverse the activity of demineralization of dental caries, you should see your caries from three dimensions. Okay, that's why let us start with the old concept in diagnosing dental caries and how we could modify it, or how it was modified already for detection of early caries lesion and determining all the condition and circumstances related to its extension and its presence and its activity. Okay, starting with traditional techniques. Okay, then going for advanced caries detection aids, then caries risk assessment. Let us start with traditional techniques, and the simplest one is to see, which is the visual examination. Visual examination is the widely used and the simplest diagnostic technique or examination technique, to be definite. Let us say examination. Okay, it relies on seeing a caries lesion. That is simple. Okay, but you should have a sharp eyes for sharp sight or definite accurate sight. That's why it is recommended to use magnification simply from dental loops. It is now available in all dental markets, okay, and easy to get one, okay, with different magnifications, okay. And we need a good illumination either from the overhead dental chair light or some dental loops having a headlight, especially LED one coupled with it, okay, and it provides a great accessibility to see the surface. Then the surface should be clean and dry, okay, because sometimes we may misdiagnose dental caries and could not differentiate between dental caries and remnants of food or any discoloration. That's why you should use the triple way serage, okay, to clean your surface from any debris. Sometimes the tooth may be covered by plaque or calculus, and that's why for proper diagnosis your patient should be or should be referred for hygienist, or may meet the hygienist before meeting you or meeting any of the other practitioners, okay, just to exclude that there is a debris or plaque or calculus that may hide a lesion or may hide a dental caries. Okay, number 4, nowadays we didn't use sharp explorer. Okay, we used round or ball-ended, what is called WHO dental probe, because sharp explorer may indicate the formation of cavitation and may lead to breakdown of fragile enamel, okay, inducing further cavitation, okay. And at the same time we will comment on this, how you could make sure that the tug-back action you felt by the explorer is not due to friction between the walls of the fissure anatomical fissure and the sides of the explorer. And when you are forcing it, already you are reducing microfracture of your enamel. There is too much questions and too much remarks about using this. This is why nowadays we recommend the use of ball-ended dental probes of WHO. Okay, sometimes for proximal lesions you are in need to use tooth separation, especially to see visually if you don't have a radiograph or any other mean to inspect visually the interproximal incipient caries. In such a condition, we may use oversized wooden wedge, okay, for a few minutes, and sometimes we are using orthodontic elastic separators for maximum 3 days, okay, just to displace the gingival tissues and to provide a little bit separation between teeth to uh, to see or inspect the proximal surface. Finally, you should have sufficient time to examine all the tooth surfaces. Examine your tooth from all 5 surfaces, the two proximals, buccal and lingual, and occlusal or incisal. Okay, it is not as simple as you inspect by naked eye the surface. It's okay, it's free from discoloration, then it is sound. No, you should inspect, have your time to inspect the tooth and examine it visually from all sides, including soft tissue and periodontium. This is an example of magnification loops with higher magnification. To the right side, this magnification loop is accompanied by a lid. Okay, sometimes some operators prefer it with light, overhead light, and I'm one. This overhead light is annoying to me. Okay, I am not accustomed to use it. I am in need much more training to use it. Okay, this is an active caries lesion, but we couldn't definitely define what is the extent of the lesion, what is the activity of the lesion, because it is covered by plaque. That's why comes the importance of cleaning the surface. Okay, cleaning the surface, as you could see in figure C, gives you a definite picture and mental imaging about the extent of the caries lesion and its activity, which is not clear as that in figure A and B, while it is covered by dental plaque. Okay. Also, the figure A in such a condition did not reflect the tooth is caries or not, is there a demineralization or not, because already it is wet with saliva. You should dry your surface, okay, washing it and drying it with triple way syringe, and you could, after dryness, discover, as seen in figure B, okay, a white demineralization area indicating starting caries activity related to this fissure. Finally, this tooth at the cervical area showing a white spot lesion. This white spot lesion may be a hypermineralization or hypomineralization. As you see in figure B, there is a cone with white discoloration in enamel, okay, indicating demineralization. Okay, if you insert a sharp explorer inside it, it is not up till now cavitated, and up till now, if you don't use the explorer like that in figure C, then it could be infiltrated with resin. It could be even go for much more simple treatment by remineralizing agent or fluoride, okay, thus just to seal the microporosities in enamel that indicating demineralization and leads to this white opaque line. That's why it is not recommended at all to use sharp explorer. It already cavitated this fragile enamel, leading to the cavitation that needs to be sealed and needs application of other artificial material, maybe GIC, maybe flow composite, and we will go for much more complicated procedure than remineralization, indicating maybe cutting a cavity, indicating maybe a bonding procedure with its technique sensitivities. That's why it is not recommended. This is a simple example why we are not recommended now using this sharp explorer. Another view showing the orthodontic elastic separators that will allow applied for few minutes if it gets a result, or maximum, okay, for 3 days, okay, to inspect, to drive your gingival tissues away and give you enough space, which is temporarily created, and the tooth will again repositioned because you are within the elastic limits of your periodontal fibers. Don't use too much separation or it will be permanent separation. It's a temporary separation. Okay, just enables you to just inspect by your eye, either under magnification or not, what is hidden in the interproximal area. This is the visual examination. The principles of visual examination depends upon the changes of the tooth structure, okay, mainly affected by the idea of how the caries gets inside enamel. Okay, caries leads to acid solubility of enamel, okay, in interrod substance more than rods. Then there will be a microporosity of enamel due to demineralization. This will in turn affect light reflection of enamel and gives you the chalky white, okay, of the enamel, or the color changes of the enamel. After that, these micropores could attract stains from food debris, and that's why it gets darker discoloration. Then it all starts by microporosities due to demineralization of enamel. Okay, this will alter the light transmission and reflection through enamel and gives you a chalky white appearance. Okay, these micropores could be sealed or occupied by stains, okay, until a full demineralization and the enamel is distracted, creating cavities. Okay, these are the stages of what you could visually see during enamel, okay, caries progress. That's why you could notice either cavitation in advanced lesions, or you could detect color changes. But all of these means that already enamel is damaged, and sometimes demineralization could not be noticed either by the patient or either by you. You are depending on how lucky you are and how your patient is keen to inspect his teeth. To that extent, he could note this chalky white appearance, which is actually untrue. Okay, that's why the decision of absence or presence of a lesion is based on subjective interpretation of the integrity, texture, translucency, opacity, location, and the color. Okay. Finally, it is concluded that visual examination reveals dental caries by either discoloration or cavitation. Okay. Let us discuss these cases in brief. Case number 1 showing caries pits and fissure on cusp tip. It's a visual cavitation. Case number B, loss of translucency and the change in color, as already enamel is going far in demineralization and the microporosities are occupied by stains from food and drinks. Okay, then comes case C, which showing chalky white appearance or a shadow under the marginal ridge. It's not only a chalky white but also accompanied in the center with brown discoloration. Another one is case D, incipient smooth surface caries lesion, okay, or a white spot in certain cases, okay, showing intact surface but already you have obvious discoloration. The same as case E, it accompanied smooth surface caries appears white or dark depending on the degree of extrinsic stains penetration. And the worst condition is accompanied by gingival recession, which shows discoloration and cavitation with plaque accumulation. Okay, let us discuss more definitely another case, which is the white spot cervical lesion. Okay, as we said before, this chalky white area, okay, that appears in this cervical place. It may be misdiagnosed, okay, with hypermineralization or hypomineralization, and the enamel didn't have any microporosities. In such a case, we are depending on what is described as disappearing, reappearing phenomena. Just imagine that this part of enamel is demineralized, having a demineralized spaces, microspaces that are occupied with saliva. When they are occupied with salivary secretions of saliva or water, okay, before getting discolored by food stagnation or extrinsic stains, at this stage, as you could see this lesion, okay, may be a lesion or it may be a normal hyper or hypomineralization without microporosities. Then you are in need definitely to diagnose the presence of microporosities, not the presence of discoloration. In an elusive trick, using our knowledge, if it is microporous, then with wetting it will be occupied with saliva that will hidden this discoloration. Okay, and after dryness, like that of acid etching, you are removing saliva from this microprocess and it will appear chalky white. That's why we will use disappearing, reappearing phenomena. Just drying it, okay, it appears. Then ask the patient to rinse or wet it again with a triple way syringe. It disappears. Then re-dry, it appears again. Then it's an active demineralization starting at the cervical lesion or this smooth surface cavities. Okay, but still it is not occupied by extrinsic stain to the extent that it could be visually diagnosed as dental caries. Okay, if it persists under wet or dry conditions the same, then there is no microporosities that affects the transmission and reflection of light. Okay, this is a simple way for white spot cervical lesion, which is called disappearing, reappearing phenomena that affects the visual examination of the presence or absence of caries activity. In general, the visual examination having an important limitation. It is a subject. It is subjectively or its subjectivity between different practitioners, guys, especially of early lesion. That's why its reliability and validity is considered questionable as a diagnostic tool in early lesions, because what I could see it by my naked eye according to my vision power or according to my experience as considered as discolored. Okay, someone could not see it as discolored. Someone could see that this is the normal color of this patient teeth. Okay, that's why, okay, its reliability and validity as examination tool for the presence of dental caries is much higher in cavitated rather than discolored lesions. Okay, that's why there is no doubt between operator and another. This is a cavitated lesion and this is a cavitated lesion. But in early discoloration, there is much more debate and much more difference subject in the subjectivity between different practitioners. That's why in early lesion it is not reliable, okay, and not accurate, not valid, okay. And now when it comes to cavitation, already we have a disaster, okay. We are on the right side. We discussed before where we go for cavity preparation and we go for determining the bulb conditions, the degree of enamel destruction, and it is it direct or indirect restoration. No, we are in need to be to the left side. We recommended just Pitts and Fisher, or even Pitts and Fisher is considered as an aggressive treatment. We need to just modify the patient attitude, okay, applying mineralizing agent to infiltrate these microporosities, stop the caries activity, reverse the condition, okay. Maximally, if we go for treatment, we go for preventive restoration, okay. Then should I wait to that extent to visually determine a cavitation to say that this tooth is caries or not? Here comes recent modifications, okay, for starting from the new century, 20 years ago or lesser, I think it's just 15 years, what is called caries detection indices. They are an attempt to correct the limitation of visual examination, okay, introduced by including reliable criteria for detecting early lesions, okay, and for monitoring clinical status of these early lesions. These indices used epidemiological studies to measure the prevalence and severity of dental caries. It's a huge work using a huge data, okay, from different countries, from different practitioners, okay. This work already entails contribution of a huge number of cardiologists worldwide, okay, all of them was iconic cardiologists and the epidemiologists, where they collect the data of what about the consensus of caries visual examination and correlate it to the histological pattern or the histological advancement of caries lesion, okay. That's why these indices were designed to describe additional stages of caries process, including both cavitated and the early non-cavitated lesions. Those caries detection indices that will be discussed in the next episodes in full details, including ICDAS, which is international abbreviation of International Caries Detection and Assessment System, which uses visual surface characteristics to measure surface changes and potential histological depths of caries lesion. It's in general, all of these indices are trying to standardize and translate what you have seen, okay, to a number, to a score, which describes a condition and sometimes describes a treatment. It's a trial to standardize the subjectivity of visual examination between different practitioners, okay? Then comes BOFA. BOFA is the abbreviation of pulp, ulcer, fistula, and abscess system, okay? This focused on the staging the most severe levels of caries disease, okay? Then comes CAST, which is caries assessment, spectrum, and treatment, which includes staging caries lesion both for early and more for severe level. And finally, American Dental Association caries classification system, which describe both cavitated and non-cavitated lesions by clinical presentation without reference to specific treatment approach, but it links clinical lesion presentation to radiographic findings and to provide an approach to identify when possible caries lesion activity over a time. This will be discussed in details in the next coming episodes. Those are the references I used in preparing this presentation. If you are in need for further reading, this is a suggested reading. Finally, don't hesitate to ask me. Feel free to ask at any time, as your questions are always welcome, by just commenting to this video, and I will reply to you as soon as possible. Or you could send me an email by my contact info, and also I will reply to you as soon as possible. Finally, thank you for assigning this time to listen to me. Please don't forget to subscribe to my channel and like this video and activate the notification to get all the updates of this educational channel. Thank you again. Yasser Al-Wasif.